So we're going to move on to segment 2. In this segment, we're going to talk about oral taxanes and how oral therapy might play a role for us in terms of treatment. What are the advantages of oral therapy? And I'm going to talk a little bit about the Araxel study that was presented at San Antonio. But first, I'd just like to ask our panel what the advantages of oral therapy are to our patient population and what you're thinking about in terms of wanting oral agents. And here we're focusing on chemotherapy. We know that most of our endocrine therapy is oral and 1 IM, but for chemo, we're really stuck with this IV therapy. Tiffany, do you want to comment on that?
Sure. I mean, I think that often the perception, at least, has been that oral therapy would be simpler and easier for our patients, although I say that's perception because we've found in the space of targeted therapy that's not always the case. But certainly to have an oral therapy gives, I think, a woman more freedom away from the clinic, perhaps not needing central access. And it really depends on the side effect profile of the oral therapy to, I think, really help in decision-making over what adverse events we would otherwise see with intravenous therapy, which is sometimes really well tolerated.
Yeah, I think this is an issue, and IV access being an issue as well. So, Claudine, any other comments on that in terms of what your patients think about IV therapy and frequency of dosing IV versus taking oral therapy?
Absolutely. I think from a patient perspective, and of course you need to take the toxicity of the given agents into consideration, but I think the default is that people tend to prefer oral therapies. And I think certainly where we are right now in the world is making it very clear that the more that we can get people away from our infusion units and the more we can have them have the liberty of getting their treatment at home, that is clearly advantageous. But I think we need to balance that against the toxicities. But I think the default is if we could give the same therapy orally, that would obviously be a tremendous advantage for our patients.
Priyanka, any additional comments?
So, coming from the area that I am in, very rural. So for us, yes, oral therapy also has an added advantage. A lot of our patients are traveling 3-4 hours from where they are, come to the infusion centers. So from that aspect also, it's preferable as long as the toxicity profile isn't prohibitive.
Yeah, it's actually really interesting because, and now we'll be able to talk to them by telemedicine visits, given our experience with COVID-19. So, well, let's talk a little bit about the data that we do have about an oral taxane, which has reported recently data from a phase 3 trial. So this study, which used a drug called Araxel and compared it to IV paclitaxel, was done in Central and South America, and patients who had metastatic breast cancer were randomized 2-to-1 to receive OPE or IV paclitaxel. And then the primary endpoint was actually the tumor response by week 19 that was confirmed 1 month later. So a little bit different from what we've seen in other registration trials, but in this situation, they had to show that they were at least as good as IV paclitaxel. So that was a reasonable endpoint, tumor response by week 19. And the total number of patients were 360 who were randomized in this trial, and many had received some other prior treatments for their metastatic disease. It's important to understand what the Araxel is, and it's actually oral paclitaxel, and each little capsule comes in a little, gelatin capsule, and so you need a bunch of them together. So most people took 10 or 12 tablets each time. And then because of one of the problems with oral paclitaxel and with any oral drug is actually that you don't get absorption because you have the pump, the P-glycoprotein pump is pumping it out as quickly as you get it absorbed. So they actually used another agent called encequidar, which is designed to try and prevent the P-glycoprotein pump pumping out the chemotherapy as quickly as it is absorbed. And it actually also enhances absorption, and it doesn't have a lot of toxicity on its own. So this drug is called encequidar. So basically the way people took this medication is a single sort of tablet of encequidar, and then they took a bunch of little capsules of the oral paclitaxel. And they took it for 3 days in a row. every week for 3 weeks in a row, followed by 1 week off. And then this was compared to 175 milligrams per meter squared of IV paclitaxel given every 3 weeks, the original way that IV paclitaxel was approved. And, these people, a lot of them had received some prior treatment. About a quarter had received prior chemotherapy, about a third had received prior taxane exposure in any setting, and of course quite a number had visceral disease. So they were our standard patients. They saw an improved response rate of about 15% difference favoring the Oraxel, and that showed a 40% response versus 26% response rate. And they didn't really see big differences in terms of subset analyses. They had the smallest number of patients who had triple negative disease, so it was a little bit harder to assess in that specific population. They saw that the responses were quite durable, with about 3/4 of the patients staying on treatment for more than 100 days and about a third more than 200 days. And of course, the follow-up is still ongoing. They did look at progression-free survival as well, and it was relatively equivalent at the first evaluation, but they have further evaluations to ahead. And then overall survival actually favored the Oraxel with a hazard ratio of 0.68, although this wasn't their primary objective. The p-value is 0.03, which is really intriguing that you could see this improvement in overall survival. I think one of the things that we were really impressed with this data was a difference in neuropathy. So if you looked at the grade 2 or greater neuropathy, there was significantly less neuropathy over time with the Oraxel compared to IV paclitaxel, really a clinically significant difference in terms of developing neuropathy. And if you just looked at the total incidence, it was 31% for IV paclitaxel and only 7.6% for the Oraxel, so really very different. So it's quite intriguing, and I think, the first encouraging data we've seen in this area. So I'm interested in what everybody thinks about this. Tiffany, what do you think? What did you think about that data when it was presented, and what would be a reason for you to use this over IV paclitaxel? Did you have any concerns about the study design?
Well, so I think you've raised some of the challenges of the design in and of itself, the control arm not being our traditional control arm dosing and schedule of intravenous paclitaxel, not having clear sort of clarity on the different subgroups and who these patients are. But with all that being said, it does appear to be favorable in terms of that neuropathy profile. We have many women who have long-lasting neuropathy as a result of their adjuvant taxane, and that can be a limiting factor then when we need to treat them serially in metastatic disease. So to be able to have a taxane that's active, that has less neuropathy, that perhaps could even partner nicely with some other oral targeted therapies and have a doublet oral regimen that enables women to stay out of the infusion suites could be really advantageous. It is a large pill burden from what you described, and so I think it will be a matter of finding the right patients that this is suitable for. And the other point that I didn't raise when we were talking about advantages of oral therapy over intravenous is actually a bit of a concern that we know practices are spending a lot of time trying to get approvals and authorizations and access for oral regimens for our patients. And so I would love to hear some of John's thoughts even on, how oral anti-cancer therapies such as this, how this would compare with simple IV paclitaxel.
Yeah, I think that's a really important point that you bring up, because the share of cost, not just for capecitabine, our current oral drug in the United States that we have as chemo, but also for CDK4/6 inhibitors has been prohibitive. This is patients who have Medicare and not secondary insurers. It's